Hello, everyone. It's a pleasure to be meeting all of you, though virtually. It's a privilege and honor to be invited to the World Down Syndrome Congress 2021. Today, I'm going to discuss about prenatal screening for Down syndrome and what are the practical aspects that we have during our day-to-day practice. The probability of a person having a baby with Down syndrome increases with maternal age. At 25 years, it will be 1 in every 1,250 pregnancies, and at 35 years, it increases to 1 in 400 pregnancies, and at 45 years, 1 in every 30 pregnancies will result in a baby with Down syndrome. However, it's important to note that over 70% of babies with Down syndrome will be born to women below 35 years of age. On another note, 79% of parents state that their outlook on life is more positive since the arrival of their child, and 99% of people with Down syndrome report being very content with their lives. But let's start at the very beginning to understand chromosomes. Chromosomes are present in the nucleus of cells. They contain DNA and protein, and these ultimately they are the genes which make up the genetic combination and give us all the characteristics that we have. Now, if you consider a book analogy of chromosomes to a book, the number of pages in the book is equal to the chromosome number. The text material in the book is the DNA, and each word is a genetic sequence. And we all know that each word has got a specific spelling, and the spelling of each word is important, and that spelling of each sequence in the DNA is also important. For example, ATCG or AATTCCGG, each genes have got a specific code that is written in the combination of A, T, C, and G. Now, genetic conditions are spelling mistakes in the gene sequence. The word enough and the word enough, ENUF, they sound the same, but they are not the same. This is the correct spelling and this is the correct sequence. This, even though it sounds the same, it is not of a correct sequence. So, spelling mistakes in the gene causes genetic disorders. Now, we said chromosomes have genes. Each of our physical characteristics are decided by the genes, and all of us have actually 23 pairs. So here is a chromosome here, and then we have pairs of chromosomes because each one of the pair comes from one parent. We have 23 pairs, and half of them come from the father, half of them come from the mother. Now, when the father or the mother, when there's an extra chromosome, which is transmitted either from the father or from the mother, then the baby, instead of having 46, will have 23 plus 24, which is 47 chromosomes. And if that extra chromosome is actually the 21st chromosome, then we call that as trisomy 21 or Down syndrome. So in Down syndrome, the total number changes to 47. But what are the types of Down syndrome that we can see? Over 95% of Down syndrome is called of the non-disjunction type. In the non-disjunction type, it's always a chance occurrence, and so it is called as non-inherited type of Down syndrome. What happens is during fertilization, either the egg has, instead of 23 chromosomes, the egg has 24, as I told you earlier, and the sperm, which 23, fertilizes that results in an additional extra chromosome. The importance of understanding non-disjunction is that if there is a child with Down syndrome born, then the subsequent pregnancy, the recurrence risk is very less, and the karyotype of the child can identify whether it is a non-disjunction type. So over 95% of cases are this type called non-disjunction. In about 4%, we have what is known as translocation type of Down syndrome. Sometimes what can happen when the mother or father is a carrier of what we call as a translocation, because in a translocation, one chromosome goes and sits on top of another chromosome. And when this happens, this chromosome becomes longer, it has additional genetic material, but it is considered as one chromosome. So when it is transmitted, when this comes here with the additional chromosome material and the other chromosome which is not translocated is not transmitted, then you have what is known as a balanced translocation carrier, which means if the overall genetic material is normal, then it is called as a carrier. That person is called as a translocation carrier. However, but if that the translocated chromosome is transmitted, and in addition, the other normal chromosome is also transmitted, so you will get one from the father, one from the mother, and the translocated chromosome, and then it becomes an additional material, and this we call as translocation trisomy 21. So if additional material is what we are looking at, and this additional DNA material constitutes towards Down syndrome, and this is called as translocation Down syndrome. Now, the third type of Down syndrome is very rare, and it is less than 1%. It is called as mosaic Down syndrome. The cause of mosaic Down syndrome is unknown, but however, we know that when there are a number of cells in the body, a few cells have trisomy 21, but majority of the cells appear normal with 46 chromosomes. But we should also understand one very important thing. There is something known as nature's law of natural selection. That if there is something very radically wrong with the conception process itself, then nature has a way of excluding those pregnancies, which results in early fetal loss, or this is early fetal miscarriage. So if you consider for Down syndrome, between 12 weeks to term, almost 40% of Down syndrome will spontaneously miscarry. And from 16 weeks to term, another 30% will spontaneously miscarry. So this is an important thing to know, that those babies which are continuing with Down syndrome, which are continuing, are pre-selected, and because they are compatible with life. Can Down syndrome be detected during pregnancy is the question. Yes, of course. And for that we have screening tests and we have direct testing, which we call which is chorion villus sampling or amniocentesis. Now, what do screening tests do? They identify patients at risk in an unsuspected population. I already mentioned mothers who are less than 35 years of age are a higher number of Down syndrome born to women below 35 years of age. So when we do a screening test, the screening test acts as a filter for patients who to select for further diagnostic testing. The screening test does not say yes or no. So what is the screening test are all about? We do ultrasound, then we do some biochemical parameters, which we call as biomarkers. And then once we apply this, there will be a software which will interpret this and say among the population which is screened, a small number of them will be called as screen positive. This is approximately around 5% or so. Now, the screen positive only means there's a higher probability of these people, of these women having a baby with Down syndrome, but it does not say yes or no. So in order to confirm or exclude Down syndrome, we need to do a further invasive testing, which we will talk about presently. So, but before the screening test, it's important to have some pre-test information, because these tests has to be conducted in a very precise manner and with the optimum information that is given, and it's all put into a software to predict the probability. If there's been a previous screening test, if any, the results of the screening test are also added, and this results in one number which we call as baseline or a priori probability. So then we do ultrasound as markers. We do biochemical tests in the first trimester, and also ultrasound in the first trimester. In the ultrasound, we measure the size of the baby, the length of the baby, which we call as crown rump length. Then there is a small amount of fluid behind the neck, which we call as nuchal translucency. The larger the amount of fluid behind the neck, the higher is the risk for Down syndrome. Then we also look at some blood flows inside the heart and also blood flow to the vein in the heart. Now, these also help us to additionally refine the probability. So, what are the steps of screening? The first and foremost step is called as pre-test counseling. Now, pre-test counseling is important because during this time, the doctor communicates with the patient and the couple about what are the possibilities, what are the possible tests that are available, and what are the fallouts of the test, how will the result come, and based on the result, what action that needs to be taken. So this is called as informed consent. And once there is informed consent, the next process is to identify what is called as the a priori probability. This is calculated by the computer. Then we do markers, both ultrasound and biochemistry. Then we apply screening algorithms to this, the results of this test, and which helps us to modify the probability. And then we identify patients for invasive testing. So here is a sample report. This patient has had a blood test and has had an ultrasound. Result of probability is 1 in 415. According to her age, she is 1 in 1283. We have what is known as a cutoff value. The population cutoff value we use in India is 1 in 250. So any number which is higher than 1 in 250, like 1 in 400, 1 in 500, we call as screen negative. And we say, well, there is no need for any further testing. But when the number is screen positive, here is a number which in this patient which has come as 1 in 74. So 1 in 74 is a higher risk as compared to 1 in 250. So this patient will be called as screen positive and will be asked to do further testing. The whatever we spoke about is the test which is done between 11 weeks and 13 weeks and 6 days. Supposing during that window period somebody has not had a testing, then there is an option of what we call as second trimester screening. This screening is called as a quadruple test. It is done between 15 and 21 weeks. The detection rate for this test is about 75 to 80% as compared to 85 to 90% for the first trimester screening test. Then we have another test which is probably the best test of all, which we call as non-invasive prenatal screening. Non-invasive prenatal screening actually looks at fetal DNA in the maternal blood. Now, as early as 10 weeks of gestation, the fetus consists of DNA, we know. Now, some of the DNA is outside of the cell. We call this as cell-free DNA, and this goes through the placenta and into the maternal circulation. So when you look at the mother's blood, mother has got her own DNA, which is circulating and in the cells, and there are also some DNA which has come out of the cells and are inside the bloodstream floating. So the fetal DNA comes into the maternal circulation. The maternal DNA is also existing there. So we have, by a laboratory test, we can actually extract this DNA, both fetal and maternal, and we can separate out the maternal and fetal and then say, okay, this DNA is of adequate quantity or it's a additional quantity, for example, in chromosome 21, where the additional quantity is present. So this is called as non-invasive prenatal screening because the mother's blood is drawn and we don't go and directly puncture the fetus to get some tissue. Now, this is usually done after 10 weeks and this has got 99.9% sensitivity, but in about 5% of the patients, we may not get a result. But this test is also a little bit more expensive, but slowly the cost is coming down. Now, what about screening in twins? We can do screening tests in twins, but there's a 10% reduction in sensitivity of the test. It is better with identical twins. Here you can see identical twins, and here we can see non-identical twins. And the NIPT has got, again, a little bit less sensitivity, but however, the detection rate is about 90 to 95%. So this gives you a gist of what screening can do. Now, let me take you through some frequently asked questions. The first question is, are screening tests compulsory? Now, the tests are only offered by the doctor. Screening is not compulsory. It is always by choice made by the couple. But before embarking on the screening test, the couple should understand, what should I do if there's a screen negative result? What should I do if there's a screen positive result? Because if it's a screen positive result, then we have to do further invasive testing. So what if my doctor does not tell me about the test? If your doctor does not ask you or offer this test, then you can ask your doctor about the available testing. And medical consultation, remember, is a two-way process. So you can put forth your concerns and the doctor will respond to that also. Now, what should I know when a screening test is negative? Now, a screening test or a negative screening test indicates that the probability of the baby having Down syndrome is less than the prescribed cutoff limit. So we have an arbitrary cutoff in the population, which is 1 in 250. As I said, in some countries it is 1 in 150. But if the result is, the risk is less than 1 in 250, let's say 1 in 300, 1 in 400, 1 in 500, 1 in 1000, for example, then we call it as screen negative. Now, if the screening test is positive, does it mean that the baby is having Down syndrome? The answer is no. A positive test indicates higher probability of the baby having Down syndrome. The baby may still be normal, so one need not worry as soon as you get a positive result. So then how can I be very sure? The only way to be absolutely sure whether the baby has Down syndrome or not is by direct testing. And this direct testing, what is meant by it, a small representative sample of tissues containing fetal cells are removed by introducing the needle into the pregnant uterus. And this direct fetal testing is of two types. One is called as chorion villus sampling, where you have the placenta, that's the fetus, that's the umbilical cord, and that's the placenta. And this is done between 11 weeks and 14 weeks. Now, after 15 weeks, we directly puncture the amniotic fluid. We take cells from the amniotic fluid because the baby's skin will be exuding cells into the amniotic fluid. Those cells are taken and then they are processed for karyotyping to look at the chromosomes. So when you do the samples when you send the samples for chromosome study, there is something known as rapid aneuploidy testing. There are several methods of rapid aneuploidy testing. This one method I'm showing you here is called the FISH test, fluorescence in situ hybridization test. Here, the result will be available in about 48 hours or so. So the other thing, of course, is looking at karyotyping. The karyotyping is a longer process. It takes about 2 to 3 weeks. And in the karyotyping, we will actually get the chromosomes in the numerically arranged. When you come to chromosome 21, instead of 2, there is an additional chromosome. So this is the typical non-disjunction type of trisomy 21, which is what we see in over 95% of the cases. So then why can't we do invasive testing for all pregnancies? Only 5% of the population will be screen positive. Invasive testing has got a very small chance of miscarriage. So in 0.5 to 1%, there may be also a culture failure and a repeat invasive testing may have to be done. When there is a structural defect identified on ultrasound, like a cardiac defect, then we do direct testing, we don't do screening. So my first baby has a Down syndrome. What else should I know? Now, we first need to know what type of Down syndrome and what to do for future pregnancies. When there is one child with Down syndrome, if there's a numerical defect, like I said, non-disjunction, the recurrence risk is low. We can do either direct or indirect testing. With a translocation down, we do the parental karyotype If the parent is a carrier, the recurrence is high. If the parent is normal, the recurrence is low. Other points, if in vitro fertilization is considered, pre-implantation genetic diagnosis can be done before the embryo is implanted. Learning in early pregnancy that baby has Down syndrome allows couples to be better prepared. So in summary, Down syndrome is a condition and not a disease with an extra chromosome 21. Recurrence is higher if there are structural rearrangements in the chromosomes. Prenatal testing is an option. Counseling by an expert will help understand the available options. Informed choice is the important thing that we need to know. Children with Down syndrome are truly adorable. Let us celebrate their achievements, and they actually teach us how to live. Thank you very much for a patient listening.